Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and today we're joined by Willis-Knighton Eye Institute. We've got Dr. Wyche Coleman and Dr. Christopher Shelby here in the studio with us today. Thanks for joining us, guys.
Yeah, thanks for having us.
Good to be here.
Absolutely. So you are our eye experts, and we've got lots of things on tap today that we're going to be talking about. Cataract Awareness Month is next month, so we'll be talking about cataracts. But before we get into it, I have a personal question, just because I always come with my own questions with you guys. I wear contacts myself. So if I were to, think about maybe getting LASIK at one point in my life, do I have to wait until my eyes fully, worsen? They worsen every time I go to the eye doctor. Do I have to wait until they get worse in order to have that surgery, if that makes sense?
First of all, great question.
Okay.
Everyone asks it. And it's totally
That's
valid.
the best question that we've heard in weeks.
That's a great question. So nobody wants to get the procedure done and then have their eyes continue changing and have to do it over and over again. We don't want to do it over and over again,
right,
because it is a low risk procedure, but the more times you do it, it's cumulative risk. Mm-hmm. So you want to do it the least times possible. So, when you get in your early to mid 20s, usually your cornea has stopped changing. And so there's a reason for that. Is that as UV light hits your cornea, the clear part on the front of the eye, and that's what we work on when we do LASIK, it causes the collagen fibers that make up the cornea to link together more tightly. We do this procedure called corneal cross-linking for people with keratoconus, whose corneas continuously change throughout their life, sometimes at a real rapid pace. And so that just applies like 50 years of UV sun, what you would get from the sun naturally, in 30 minutes, and it stops the cornea from changing. Now, people who have normal corneas, by the time they're in their 20s, you've absorbed enough UV light into your cornea that those fibers are bound tightly enough together where you're not going to change much after that. So I always tell people, if you're like a -3 or 4, do you know what your prescription is?
It's not too bad. It's -2 on my left eye, -1.5 in my right eye.
Not huge,
yeah.
And so it's probably been relatively stable for a while. Mm-hmm. So it's a great time for you to do it. You probably won't change much. Now, if somebody's like a -10, they have a huge prescription, might they continue to get a little bit more nearsighted as time goes on? They might, but people who are that nearsighted, they're a non-functional human being without glasses or contacts. Mm-hmm. They can't walk across the room, they can't cook for themselves, they can't live their lives without contacts or glasses. So even if people who are real nearsighted are more likely to drift, but even if they drift a little bit and you get 5 or 10 years down the road and you got to wear a little pair of glasses tonight to drive at night, at least you're still a functional person.
Right.
Otherwise, and you can always come back and do a touch-up if you have to. Generally, the younger end of the spectrum, we kind of stay away from that, but there was a pediatric practice that did LASIK on children down to 14 years of age, and they showed in a study that they published, which was fascinating, that if you corrected people earlier, you had a lower rate of progression. So I don't think that there's a definitive cutoff. It's somewhat circumstantial. I had a patient one time that was a friend of mine. She was a helicopter pilot. She was learning to fly helicopters. It's windy in a helicopter. She was intolerant of contacts, and we did her at 18, and we do some kids who are 18 years old because they have a specific reason that they just can't wear contacts. And 10 or 20 years from now, you're a little bit more likely to need a touch-up, but it's worth it.
Yeah.
Especially if you've documented not a lot of progression. Now, if you're going every year and your prescription's changing a whole lot, let's say it changes like by 1 diopter, like it changes from -2 to -3 to -4, then you probably want to delay a little bit. But if it's just going from like a -2 to a 225 over a year-long period of time, that's relative stability, and you're fine to go ahead and have LASIK at that point.
Makes sense, yeah, and it's all probably individualized. It's something that's maybe determined by you guys when you look at their eyes and their prescription and how it's changing.
Yeah, and we typically just ask somebody, when you've seen the eye doctor, have you had a big change? When you go, are your glasses like not working at all anymore? Or are they about right and you just got to tweak them a little bit? And if they say, well, for my last 2 or 3 visits, I've just had to tweak them a little bit, I've still been able to live with them fine, you'll probably have enough stability to get LASIK.
Gotcha. Cool. Well, thanks.
Yeah.
For that. So I wear contacts, and a lot of people out there wear contacts, maybe miswear them, misuse them. Maybe talk about the importance of taking them out every single night, not sleeping in them, and what could that lead to if you don't properly take care of them or clean them.
Yeah, when you look at the statistics of contact lens overuse versus any refractive surgery, PRK, LASIK, or SMILE, it's infinitely more dangerous to wear contact lenses than any refractive surgery that we do. And what people will do, especially the higher minuses, somebody like you can take your contacts out and you can function. But like Dr. Coleman was saying, somebody who's a minus 6, 7, 8, 9, they can't see without correction. And so they're more likely to overwear their contacts, especially when they're younger. And the issue there is corneal ulcers. And some of these bugs that create infections on the eye can eat through the cornea in 24 hours. And we've done a number of LASIK patients where we do LASIK on one eye and PRK on the other one because they have scarring secondary to an old infection. And so that can be very dangerous with contact lens overuse. So the best contact lenses you can get are the dailies, the ones you put in the morning and you take them out and throw them away at nighttime. And of course there's some economics there. So, but even if you're wearing the extended wear, the best thing to do is put them in and take them out at night. Give your eyes a breather. And if you're wearing a contact lens, your eye turns red and gets real irritated, you need to take it out immediately and come see one of us.
Okay, yeah, good to know. And you don't want to, if they're dailies, you don't want to wear them 2 to 3 days, or if it's monthly, you don't want to wear them for 2 months.
Right, daily doesn't mean every day.
Yeah,
so.
Yeah, okay. Very interesting. That's a little alarming too, but with the surgeries that you're talking about, or the laser things, is any of that covered by insurance, or what would that look like?
LASIK is typically all cash.
Okay.
It's just totally elective. Some insurance plans say we pay for it, but what they really do is they contract with a discount provider and then just get it done at a discount. So,
Okay.
But
Yeah.
we don't really participate with too much of that. Our equipment is too expensive to get involved in that.
Because I was thinking, with contact lenses, they can be pretty expensive.
Yeah.
And so I'm just thinking of the payoff. If you do the surgery, you may end up saving money later on if you continue to wear those contacts. Would you say?
Yes, there's a great paper that was published that showed definitively over a 10-year period, LASIK is safer and cheaper than contact lens wear.
Gotcha. All right. Well, Jan, thanks for joining us. What's your question?
Well, I have the start of a macular hole in my left eye, and I was wondering if it was safe to get cataracts taken off on that eye.
Yeah, that's a good question. And the short answer is yes, it is safe, but we always coordinate with the retina specialist because some of the inflammation that's caused after cataract surgery can lead to more swelling in the back part of the eye, and that would be the only issue that we would watch for. And of course, if the macular hole gets bad enough, a lot of times our retina colleagues will go in and peel.
He said there's like a gel, and it's pulling on it, trying to start. And I had one in my right eye, and now I got one in my left eye.
Have you had surgery on it yet?
Oh, on my right eye, I did, yeah.
Okay, all right. So,
But not this one, not the left eye.
Yeah, so, and what happens is that membrane pulls traction. So we initially see what we call an epiretinal membrane or cellophane maculopathy because it looks like somebody stretching cellophane, get these little ridges in there. And of course, when that traction happens, it begins to open up that central area right over the macula. And generally, there is a perfect time for the retina specialist to go in and peel that. But yes, it is safe to have cataract surgery with even the beginnings of a macular hole. It just needs to be coordinated with your retina specialist.
Oh, okay. Well, thank you very much.
All right, Jan, you're welcome.
Yeah, Jan, thanks for joining us. And if you're just joining us, you can give us a call, 318-219-4569. We are talking about eye health. So if you have a question specific to that, give us a call. And that brings up another good point. If someone is wanting cataract surgery, are there any indications that someone is not a candidate for that?
There are some cases, especially with retinal pathology. She talked about a macular hole. Macular holes are common, or what we would call an epiretinal membrane, where there's a film over the retina and it's distorting it slightly. Now, in most of those cases, the retina specialist, if there's a cataract there, they may say, you need surgery on your retina, but a lot of times they say, you need to get the cataract out of the way first so that they can have a good enough view to do the retina surgery.
Gotcha.
Now, there are some contraindications for cataract surgery, especially if somebody is especially prone to a retinal detachment. If they have some pre-existing pathology, we may say, we don't want to do cataract surgery. Usually we don't say we don't want to do it at all, but we don't want to do it right now until these other issues are controlled.
Gotcha. Well, Shan, thanks for joining us. And what is your question today?
Well, Shan, thanks for joining us. And what is your question today?
You talking to me?
Yes, ma'am. What's your question?
I was wanting to know if either one of those doctors know anything about Coates disease. My daughter has Coates disease.
Yeah, Coats disease is a a disease of the retina itself, and we usually refer those out to our retina specialist. And if my memory serves me correctly, you can get some aneurysms in the retinal vessels, and it causes some leaking and bleeding in the back, and that's usually controlled with either injections or laser.
But there's no cure for it?
No, ma'am, not really a cure, but there are some treatments.
Okay.
No, ma'am, not really a cure, but there are.
Okay. All right. Thank you.
Yeah,
All right,
thanks
you're
for joining
welcome.
us.
Thank you.
And if you have a question, give us a call, 318-219-4569. That number is right there on your screen. So sticking with cataracts, it's one of, or is it the most common surgery performed, or one of the most?
I think it's the most common in the United States.
Wow, yeah, and I love how you say it's a reward for birthdays. It's kind of not when,
Right.
or it's not if, but when you're going to need this surgery. So what would happen if you didn't have cataract surgery?
You know, your vision will just progressively get worse. A lot of people come in and they they don't see perfectly, but they say, you know, I'm seeing good enough. I'm not wild about having surgery on my eyes. I don't blame them. And I always tell them, you know, if you can still pass a driver's test and do whatever you need to do, if it's not bothering you, it's not bothering me. You know,
Yeah.
so some of them come in and they say, someone told me I must have cataract surgery. Well, that's not usually the case. Now, if you can't drive and you drive for a living, you know, or you can't pass a driver's test, or you can't walk around your house and live your life, well, there starts to become a lot of pressure. But a lot of times it's that this is bothersome and annoying me all day. So can you live and pass a driver's test? Probably. Is it optimal? No. And then it's a personal decision on the part of the patient to say, how much am I bothered by this? To take the leap to do surgery. Surgery's super safe, but it is not without risk. So, you know, we don't want to pretend that it is, and it needs to be bothering somebody to a threshold level where they're ready to get something done about it.
Great, yeah. Well, Lonnie, thanks for joining us, and what's your question?
Know about this style. It's STYE, and this is something that I've had for a second time. I had it about 2 years ago, and it came back again. And I want to know if there's something deep rooted in this that's causing this, other than just bacteria on the skin.
Yeah, STI is a what we call an external hordeolum, fancy word of saying that those little hair follicles on the eyelids are getting infected. You know, of course, it stacks up with the normal bacteria that generally grow on your skin, and you get that white bump. A couple things you can do is keep the eyelids clean. You know, do eyelid scrubs. Those are commercially available over the counter. Warm compresses. You know, make sure that any eyeliner, things like that, are completely removed. Omega-3 fatty acids are as a supplement can be very helpful. If they're happening back to back quite a bit, there's certain antibiotics oral that can be used, and some antibiotic ointment. But I would start with keeping the eyelid margin as clean as possible. So at night, do a little warm compress. Use some of the eyelid wipes that you can get over the counter. Do that for a few weeks. I think you'll notice some resolution.
Thank you very much. I appreciate it.
You're very welcome.
Absolutely.
You know, I might chime in on that one and say, because I've made the mistake myself, when you start to get a sty, you get that painful bump on your lid, hot compress it like crazy. You know, if you can get 20 minutes of heat 2 or 3 times a day, that'll make a big difference. And you know, I've gotten one once or twice myself and neglected to do that, and ended up on multiple antibiotics for a couple of weeks. And I thought that I was going to have to let Dr. Shelby drain it. We got close, but we narrowly avoided it.
Wow.
So the sooner you can hot compress it, the better, because it will drain on its own in that case.
Wow.
More heat for a longer period of time is very helpful.
Is there a reason why someone would maybe have it multiple times or recurrent?
Yeah, you know, it's usually what we call poor lid hygiene. You look at the lids and there's just a lot of buildup on them. A lot of times, especially in females, no offense,
right. I figured.
it's
Makeup.
just tough to get all the makeup
Yeah.
off, and so
Yeah.
you end up with some of it caked up on there, and that's a place that harbors bacteria. And then as you get older, your meibomian glands that produce the oily layer of your tears, they just don't flow as fast, and they start to get stopped up. That's the reason fish oil is helpful, because it reduces the viscosity. It makes that oily tear production thinner, makes it flow faster, leaving less of an opportunity for those glands to get stopped up and infected.
Interesting. Yes. Well, I don't go to sleep with my makeup on, so that's a good thing.
It's a good
too.
start.
Yeah, we don't either. So
Oh,
it's
good.
all
Yeah,
good.
Well, love that. So yeah, good information for that too. But going back to cataracts as well, leading up to cataracts, what is maybe the prep work that someone can anticipate?
Well, they'll come in and of course we take measurements. We pick a lens, with the patient's input, because we have lenses that allow them to see, really well at a distance. Need readers. We have lenses that allow near, intermediate, and distance vision. We can correct astigmatism. It's all based on the patient's needs. And so once that's done, it's really quite easy. They come to the surgery center. The girls there are wonderful. IV started, little sedations given, and the whole process from the moment we start surgery to the moment we're done is 10 to 15 minutes. It's not long at all. They generally see well that day, a little foggy, hazy as that pupil comes down, the swelling goes away. And what's interesting is when they come in for the second eye, everybody's real nervous for that first one, but they come in for the second one and they're excited because they know it doesn't hurt, it's a pleasant experience, and they're going to see better almost immediately.
Mm-hmm. Yeah. Is there any time where you've noticed that it's too far past that window to have cataract surgery?
Never.
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 Okay.
No matter how dense the cataract gets, and when we go, and I've done a few of these trips to third world countries, every cataract there is harder than the most dense cataract you may ever see in your whole career in the United States. And those people still get good vision. Now, some other techniques are required to get out a cataract that's more dense. Sometimes they're so dense we can't break them up with ultrasound, but we have great techniques now, so there's almost no limit to the density of the cataract that can be removed and provide a lot of benefit to the patient. The good news is when they get that bad, somebody might even just be seeing light or just motion. They can't read anything on the screen.
Oh, wow.
And then it's not uncommon for somebody like that to be 20/20 right after cataract surgery, which is an amazing thing.
Wow, yeah. And so when you're talking about the density of the cataract,
Yeah.
is that from the proteins that break down?
Correct.
in
So
it?
they build up over time, and sometimes they can be so dense that you could see them from 5 feet away where the pupil's just white or the
okay.
pupil's brown and no light at all, no useful image is getting to the back of the eye at all. And those are the people who sit up on the table and start crying because they hadn't seen good in years and they've been totally non-functional, and suddenly they can see again. It's like a modern miracle.
Wow. Yeah, and that's typically not here in the United States. Usually, when you're
We
you could
see
probably
some,
see that
most
too.
of them are from Red River Parish or Natchitoches or something like that. It seems like I don't know why there's more people. I had a lady one time who she was pretty young. She was in her 60s, and she was in the nursing home, and she was in the nursing home because of her vision, and nobody had thought to look at her eyes and consider whether the cataracts were the problem. And she had bilateral white cataracts. She could only perceive light, and we did cataract surgery, and she was 20/20 in both eyes.
So when you're saying you can only see light, you're basically blind.
You're basically blind.
Yeah.
You would run into the wall if you tried to walk across the room.
Wow. And you guys, with your trained eyes, you could just look at somebody probably and see that if
Sure,
it's that bad?
you're always wondering, what's behind there, because in those cases you can't see the retina. There could be a retinal problem that you can't see, and you have to get the cataract out to uncover that, and maybe their vision won't improve. But this was one of those cases where there was absolutely nothing wrong except the cataract. So as soon as we did the first eye, the lady was 20/20, and she left the nursing home and lived independently after that. So that's a big
incredible.
win.
Yeah, it definitely increases your quality of life for sure.
For sure.
That's a win too.
Yeah.
So, yeah. Well, thanks, Mike, for joining us. And what is your question?
My question for the doctors is this. I had a stroke that didn't last but very few times, and I've had cataract surgery, and I wore contacts in the past, and I was nearsighted as a kid. But after the stroke in my right eye down in the corner, like if you were looking at that screen the monitor, it would be down where the K370 is in my eye. And it's kind of like a little web down there, and it kind of interferes at times. But the upper part of my eye is very clear. What would that be?
Well, it sounds like what we call a branch retinal artery occlusion, where one of those blood vessels that goes to the retina got occluded, which effectively is a stroke. And so it ends up knocking out that part of the vision. Now, a lot of it depends on where the stroke was. Was it in your eye or in the brain? Because if it was in the eye, go ahead.
Go ahead.
Because if it was in the eye, that area where the blood flow is reduced is damaged. So it doesn't pick up the image quite as well, and you get what we call a scotoma. So when you're looking straight ahead down here, you don't see it as well because in the back of the eye, the stroke was up on the top part of the retina. You can have a stroke in a certain part of the brain where the visual pathways are that could be very similar to where you don't see in a certain quadrant of your vision, but it's usually on both eyes. So you close one eye, it's in this spot, you close the other one, and it's also in that same spot. And it would depend on where along that pathway that stroke was.
Okay, it's only in the right eye at the bottom right, and that's it. And I didn't know whether anything could be done with that to correct it or not.
Let me ask you, how long ago was that?
About a year and a half.
Okay, and hopefully they did a bunch of testing to make sure that to find out where it came from. Because the issue is that if that happened inside the eye, the first big branch of your internal carotid artery is actually your ophthalmic artery. So that means that if there was an issue with that artery in the eye, there could be future events that could be much worse. And so we like to make sure that you're not at risk of having a bigger stroke in the future. Now, that being said, to your point, there's really nothing we can do except for time. And those scotomas that develop with the artery occlusions are always there. Your brain tends to adapt to them to a certain degree, until you recognize it, and then it's like it's in the forefront. But it should not get any worse. That's the good news.
Okay. Well, thank you very much for your information. I appreciate it. And if I see something, I think I'll contact you guys and come see you.
Please do. Yeah. If there's any other issues at all, or if you want to even have us take a look as a second opinion, we don't mind at all. So, thank you, Mike.
Okay. All right.
And do you mind sharing y'all's phone numbers?
Yeah, 318-212-5901 is mine.
And 318-212-3937 is mine.
All right. Yes. And Jim, thank you for joining us. What's your question?
Yes, sir. Good afternoon. Could you tell me what physicians that are in town that would be able to correct a problem where children quite often experience it, but this would be for a senior citizen adult where like something's wrong with your muscular problems and your eyes are not straight, they're not tracking together, so you end up seeing double vision. The eyes are okay, but like one's a little higher than the other.
Yeah, so the key question is why, and maybe that's already been answered in your case. And if you know you need surgery, we can see that initially, but if you know you need surgery for it, there's actually only one option in town now, and that's Dr. John Hendrickson, and he does a great job. Dr. Richards was his partner. He retired, I guess, earlier this year. Mm-hmm. So he's solo, and I think they've got a partner coming in. So he's pretty busy, but he will do adult surgery and kid surgery. So it's sort of a pediatric clinic, but adults go there too because it's typically the kids who have eyes that are not straight, that are crossed, and that's who those surgeries are primarily done on. But in certain cases, adults need it too, and that's who we send those people to. So if you already know you need surgery and you're just looking for somebody to do it, Dr. Hendrickson is the guy.
Okay. Yes, I was diagnosed with him, and I was just wondering if there was more than one. But I appreciate it. He's the only one in the Shreveport-Bossier area. Is that correct?
That's correct. Yeah, we're a little low on pediatric ophthalmologists now, but he does a great job.
Yeah. Yeah, thank you, sir.
Thank you. I thought I may hit on LASIK one more time. Yeah. I'm going to give you my LASIK spiel, so you've already had it, and so. We're going to keep trying to slowly convince you. So, the deal with LASIK, and with every procedure, I think that determining risk-benefit is always the key. Like when to have cataract surgery, when to do LASIK. A lot of this language of safe and effective was used during COVID. It was popularized. That's not so great because the problem with it is when you say this is totally safe, well, somebody can Google in 5 seconds and find somebody who's been blinded by LASIK. Those people exist. Right. There are risks. I tell everybody, worst thing I can do is blind you and you lose the eye anytime we operate on it. That is a fact. What's the probability of that? Super low, so we got to find a benefit that outweighs that risk. And so with LASIK, I break it down into two separate categories. Number one is risk. So what is the probability with LASIK that we're going to cause you to go from 20/20 or better to 20/40 or worse. That means, you're visually disabled, you can't drive, and we can't correct that with glasses or contacts. If we add up all possible complications, infection, epithelial ingrowth, inflammation, everything bad that could happen that cause permanent irreversible vision loss, the overall risk is 2 per 1,000 in a given eye. So by extension, the probability that we would visually disable you in both eyes is 4 per 10,000. So that's the risk that you have to be okay with in order to proceed with refractive surgery, with LASIK or SMILE or whatever. Now, if you compare that to people who sleep in their contacts, they incur that risk at 1 year of contact sleeping. So contact sleeping is super risky. No one should ever do it. People who do not sleep in their contacts, who religiously take them out every night, incur that risk of a 2 per 1,000, 2 lines or more of vision loss at about 5 to 10 years. So if you look at it over a decade, no matter how you use your contact lenses, because of infection risk, LASIK is safer. Now, sometimes people come in and they say, I don't ever wear contacts, I only wear glasses. Is LASIK safer than glasses? No. Glasses are as safe as it gets. So if you love your glasses, roll with it. And then, the separate topic is efficacy. How likely are we to get you seeing as good or better after LASIK than you see with your current glasses or contact prescription? And if you correct to better than 20/20, the probability that you will be that good after LASIK overall is about 96%. So the obvious follow-up question is, well, what happens to the other 4%? Well, those are people that we program in a treatment, and then it treats something slightly different. The outcome is a little bit different. There is a small amount of variability, and we have to come back in the near term, within 3 months, and do a touch-up. So that occurs about 4% of the time overall. Now, usually that's people who have a very high prescription. It sounds like yours is pretty low. So if people have a lot of astigmatism or they're really, really nearsighted, they're more likely to have a slight error that we have to come back and touch up, because the probability of a miss is proportional to the magnitude of the treatment. So it's a percent difference. And so if you have a bigger treatment, you're more likely to be a little bit off. So somebody like you who's like a -2 or 3, the probability that we'll hit the nail on the head and make it perfect the first try is about 99%.
Gotcha.
So that's how I break it down into safety, and efficacy in 2 separate categories.
Right.
And I think that's a good way to look at it, and that hopefully helps people understand the risk and benefit equation of LASIK that we're trying to get to.
For sure, and especially in comparison to contact use, if that's where someone's at right now.
Yeah, so if you look at it over 10 years, it's going to save you money, and you're going to be less likely to have a permanent vision-threatening complication from LASIK than you are from contact use.
Right.
No matter how you slice it.
And that's with LASIK, PRK, and SMILE.
Correct.
And what about with cataract? What is the similar risk-benefit ratio?
Similar, but cataract surgery is a little different because you're already not seeing good in most of those cases. So it's, with LASIK, you can see good with contacts. We're just trying to get the convenience of getting you out of them. And with cataract surgery, the vision's bad, and you've got to do something. So it's, it's a little bit more voluntary and elective with LASIK.
Gotcha. Yeah. All right. Great explanation. Especially for people that like the numbers and the probability of things. I think it can put some people at ease for sure. So.
I don't know if everybody likes it, but it seems to make sense to me.
I know, because some people, we don't like to talk about the risks, right? But I mean, with anything, anytime you are undergoing surgery, there's always going to be a risk. But like you said, the benefits got to outweigh it. So,
right.
Sure.
Yeah.
There's a risk when you rub your eyes. I mean, let's face it. So there's nothing without its risk. But any surgical procedure is always going to have it. But like Dr. Coleman said, it's always a risk-benefit analysis.
Yeah.
And we're really good about looking at all the variables and the metrics on patients to make sure they're not at a higher risk of having one of these issues.
Right.
And that's where a lot of the technology has blossomed over the past 5 to 10 years especially.
Yes, and you've got a new laser, right, that for people that are, you're underneath that laser for less time, which is
that's
better.
good. That's good. Yeah. Less time is a good thing. Yeah, we have the greatest laser technology on planet Earth by far. It's amazing. And so that's evolved, so the procedure itself has gotten safer and more accurate. And then the other thing that's happened is the screening tools to say, do you have a contraindication to this? Because there are some people who come in for a LASIK eval and you say, this is a bad idea for you. You need to stick with your contacts or glasses because the potential benefits do not outweigh the risk for you. And that's where proper screening is key.
All right, well, we are out of time, unfortunately. Really quick, those phone numbers one more time.
318-212-3937.
And 212-5901.
You can
And
go
give
to
them a call.
thecataractsurgeons.com.
There we go. All right.
Uh,
Thanks for joining us, and we'll see you next time.